Hi, everyone. This is Dr. Jack West. I'm a medical oncologist and the founder and CEO of GRACE, the global resource for advancing cancer education. I'm practicing in Seattle, Washington, and I'm very happy to be joined today by Dr. Natasha Leighl, friend and colleague of mine for many years, who joins us from Toronto. And she is an associate professor in medical oncology there. And she works at Princess Margaret Hospital and has been one of the leaders in the field of lung cancer, both research and clinical practice, for many years. But this is probably the first occasion that we've had her for a GRACE program. So it's definitely high time that we did, particularly since we are trying to be an international organization, and Canada's not too far, but it's great to broaden our presence and have Dr. Leighl join us at this point, especially for such a critically important and welcomed topic as highlights in lung cancer from 2012. It's always a very appealing and highly anticipated program every year. And with that, let me turn it over to Dr. Leighl.
Thanks so much, Jack. I'm delighted to be here tonight. Jack asked if I could review some of the highlights in lung cancer in 2012, and as many of you know, lung cancer is really becoming many different diseases, and so what I tried to do for this evening is to bring out the highlights in some of the different types of lung cancer to make it more applicable to your situation and the types of lung cancer that you want to know about. I'm going to talk a bit about EGFR mutation-positive lung cancer and a very large study that's established one of our newer drugs as a new standard option in the treatment of EGFR mutation-positive lung cancer. I'm going to talk about an important trial that's just been completed in ALK-positive lung cancer, and I think is helping us expand crizotinib use to the rest of the world. An emerging target, something called ROS1, and also those groups of people with certain lung cancers that we don't hear a lot about, people with KRAS-positive lung cancer. It's actually our most common kind of molecular abnormality in lung cancer. Also people with squamous cell. I'll look at some of the recent research that's been done this year. And things that don't have to do with some of these mutations, an immune-based approach. We're going to talk about programmed death protein 1. And also chemotherapy as an extension to the current first-line treatment for advanced lung cancer. So, as many people know in lung cancer, one of the greatest things has been our ability to try and better tailor treatment to the kind of lung cancer a person has. So, we no longer say just lung cancer or non-small cell lung cancer. We're really trying to subdivide it into groups such as adenocarcinoma and squamous cell carcinoma, and even within those groups to look at some of the different molecules or gene abnormalities that can drive a cancer's growth and maybe a better or smarter way to target a person's cancer rather than just general chemotherapy. And we've certainly made some progress in adenocarcinoma with a number of abnormalities here that we've identified and treatments to target them, and we're starting to make very clear progress in squamous cell carcinoma as well. So the most common mutation for which we have a great treatment option is EGFR mutation-positive lung cancer. Most people, over 90%, have mutations in two parts of what we call the epidermal growth factor receptor gene, exon 19 mutations or deletions, and also some mutations in exon 21. About another 10% of people, though, do have less common mutations, and the goal is to get all of the people with this type of lung cancer on an EGFR inhibitor that targets that specifically. And it's about 10 to 15% of people overall around the world with non-small cell lung cancer. So there are a lot of drugs out there, and I've used what we call the generic name. I'll also mention the trade name because it's more familiar and easier to say. Gefitinib or Iressa and erlotinib or Tarceva are some drugs now that we've had a lot of experience with for over a decade. But there are some newer drugs as well that are coming out. In particular, tonight I'll mention afatinib and dacomitinib. These are some new drugs that are being developed, and I'll cover a recent trial focusing on afatinib. But there are also other drugs as well, a drug called acatinib, which has been developed and approved in China. This is just one drug of a number. This is a compound from Clovis Oncology, CO1686. And when we talk about more potent EGFR inhibitors or irreversible EGFR inhibitors, often what we find is that these can have a higher affinity for the epidermal growth factor receptor. And very fortunately, a lot of these have activity in cancer cells that have become resistant to EGFR tyrosine kinase inhibitors, in particular those that have demonstrated a mutation also at T790M locus. So the study that was presented in 2012 that I think has the biggest potential to change the way we treat cancer this coming year in people with EGFR mutation-positive disease was a study that compared afatinib, one of these newer irreversible EGFR tyrosine kinase inhibitors, to chemotherapy in the initial or first-line setting. And the chemotherapy used was pemetrexed and cisplatin, and this is really one of our best chemotherapy options, with or without Avastin, compared to our other chemotherapy options. Everyone who participated in the study had an EGFR mutation in their lung cancer, and 2/3 of people went on to EGFR inhibitor. So this is a progression-free survival curve, and what this is a measurement of how long people were on treatment until the cancer grew, and at that point, most people stopped and switched treatment. The line here in blue reflects people and the time that they spent receiving afatinib, and you can see that it's actually substantially longer. People were able to stay on the EGFR inhibitor longer with this than they were here in red on chemotherapy, and it's certainly more than double in the most common types of EGFR mutation-positive lung cancer. So far, this study is certainly one of the largest studies in EGFR mutation-positive lung cancer, and they've really raised the bar here in terms of comparing it to our current best chemotherapy. They also expanded the group of people that could go into the study to include a number of people with less common mutations. So it's nice to be able to have some information about EGFR inhibitors compared to chemotherapy and outperforming it in people with less common mutations as well. And it was very clear that afatinib, or the EGFR inhibitor, was the winner. It improved the time to growth of cancer. It improved response rates, and I'll show you some of those numbers in a minute, and also quality of life compared to chemotherapy, as you might expect. And it adds a new treatment option for people with EGFR mutation-positive lung cancer. Currently, there are a number of expanded access programs that are opening or already open around the world to allow people access to afatinib for treatment of their EGFR mutation-positive lung cancer. So what does this mean in the bigger picture for us? So people outside the U.S. have access to a drug called gefitinib or Iressa, which is very well known based on a study that was originally from Asia, the IPAS study. Erlotinib or Tarceva was developed in Europe and compared to chemotherapy and is far more widely available in the U.S. and is the most common treatment for EGFR mutation-positive lung cancer patients, particularly in the U.S. Afatinib adds another option, and you can see these top curves here, the EGFR inhibitor, they all outperform our current best chemotherapies. So the big question is, with at least 3 players now on first base with the addition of afatinib, how do we choose? And the truth is that we don't have a great trial yet comparing one EGFR inhibitor to another in a very large group of people. There have been some smaller studies that have looked at this, and there are also some larger trials that I'll talk about trying to pick the winner or figure out which one is best. But certainly they all look pretty good. So with afatinib or erlotinib or Tarceva, you're looking at about a 60% response rate. In the IPAS study, the response rate looks a little bit higher, but you'll notice that these 2 studies have far more similar results looking at people treated with chemotherapy, about 15 to 20% shrinkage. But on the IPAS studies, people seem to do a little bit better, and this is probably a function of how we measured it and who measured the cancer shrinkage. A person's oncologist, believe it or not, is actually a lot more optimistic about benefit when they measure how well your cancer is doing, and sometimes the radiologist, who doesn't have a personal relationship with the patient or isn't in a busy clinic or doesn't have the whole picture of how a person's feeling, might be much more conservative. So that's probably why these numbers are smaller. So basically, all of these drugs are very active. There are other drugs as well, such as dacomitinib, which have very similar shrinkage rates in the first-line setting. But choosing is going to be hard. So when there's no clear answer in terms of which one's better, we then turn to side effects or toxicity. Now, we don't have direct comparative trials for this either, but based on people's experience, gefitinib or Iressa tends to be the gentlest with the least likely chance of severe diarrhea or severe rash. Erlotinib, which is very widely used and is very well tolerated by many people, a slightly higher risk of rash in particular. Afatinib has a little bit more diarrhea in this particular trial, and people have, again, very similar rates of rash to erlotinib. And we also see very similar findings with some of these other new drugs, such as dacomitinib. So perhaps more intensive side effects. And the question for us will be, well, what is the reason to use one of these drugs compared to the other? Some of it will have to do with access. So some of you will be able to access certain of these agents, and they certainly all work very, very well. We are looking at toxicity as one potential reason to choose one drug over another, and obviously not everyone gets these toxicities, so it is certainly reasonable to try any of these at the start. But there's also a lot of research going on to look at which of these is better. There are at least two very large studies that are ongoing, one looking at afatinib, another looking at dacomitinib, and comparing both of these to gefitinib or Iressa. And hopefully these will not only tell us about how well we can shrink the cancer and how long we can keep things under control, but also tell us about side effects so we can make better decisions. There are also some other trials that are ongoing after chemotherapy comparing dacomitinib to erlotinib or Tarceva. But I think what's very interesting for a lot of people is, well, what do you do after you've had your EGFR inhibitor, even if you have or haven't had chemotherapy? And so there are a number of different studies that are going on. I don't have results for you tonight, but I thought that I would briefly cover some of what we do have in terms of trials that are out there. So in terms of these irreversible EGFR inhibitors after some of the reversible earlier drugs, such as Tarceva or erlotinib or Iressa or gefitinib, we have some studies of afatinib compared to placebo after people had tried everything else, and a similar trial that's ongoing in Canada called the BR26 trial, where we're looking at dacomitinib or another one of these newer EGFR inhibitors. Certainly there's been a lot of promising activity in these studies, and I'll talk just a bit about that. And then also newer agents, so drugs like the Clovis compound as well as others, and trying to figure out how well they work after your first type of EGFR inhibitor stopped working. And finally, a combination strategy. Should we be adding things or changing how we give some of these drugs to keep people's responses and benefit going? So this is one of my patients who was on afatinib. She's a lady who had previously been on Tarceva for nearly 2 years. In Canada at the time, we weren't doing mutation testing routinely, so we were putting everybody on Tarceva after they'd finished chemotherapy, and she did very, very well. And when her cancer grew, we had an opportunity to put her on one of these studies of these newer irreversible tyrosine kinase inhibitors, and in particular this one's afatinib. And it's a bit challenging to see here, but this is a slice of her CT scan. And what it is it's as though you're standing at the foot of somebody's bedside and you're just looking at a particular slice of them, so to speak, and looking up towards them. So this is the left side, this is their right side, this is the person's back, and this is the front of their body. These are their lungs here, and all of this black coloring here is air in the lungs and is a good thing. These small dots here are cancer, and this cloudy area is something that we call lipidic change. And so the old name for this was bronchoalveolar carcinoma, or BAC. And you can see that on treatment, we actually have some clearing over here, and this particular person has been on afatinib now for nearly 2 years and benefiting quite a bit. And you can see here, this is a more subtle change. This one's perhaps a little more dramatic. Again, this area is all cancer or BAC type change, and you can see some very nice clearing. One of the challenges is that when an EGFR inhibitor stops working, there are a number of different reasons for that, and not everybody's reason is the same in their cancer. One of the most commonly identified mutations is at T790M. It's about half of people. There are also other changes, though. We think that people can have their cancer start signaling through other molecular pathways, whether it's MET, mesenchymal epithelial transition factor. There's a new marker called AXL that's recently been described, as well as other things, vascular endothelial growth factor, which drugs like Avastin target, and other things as well. And I think my approach when I talk to people about what to do next really depends largely on whether or not I think that EGFR mutation is still very important, or the cancer is still EGFR dependent, or whether it's more independent. And clearly we have a lot of work to do here to help split out whose cancer is in which camp. Now, in terms of potential options moving forward, we can try and target some of these escape pathways, so switching to an EGFR inhibitor that has more T790M activity, such as dacomitinib or erlotinib, perhaps some of these newer compounds like the Clovis Oncology compound. Adding something to target MET, so there have been some studies such as the onartuzumab or METMAB study, as well as some other tyrosine kinase inhibitors. There's also a study that's ongoing where we're targeting AXL as well as MET and an EGFR inhibitor, and even adding something to target VEGF, such as sorafenib. You can add chemotherapy, so if someone's been on Aresta or Tarceva, you can add chemo to see how things change. That's something that's still an experimental or research question, and I'll show you one study that's ongoing to look at that. And people, I think, are quite familiar with targeting the epidermal growth factor receptor from both ends, both the inside or the tyrosine kinase part of the receptor and also on the outside with a monoclonal antibody. Or if you really don't have that same degree of EGFR dependence, switching to chemotherapy, which is not popular but can be incredibly helpful. And so these are some of the approaches that I talked about that are in clinical trials, and some of these trials are soon to open, we're hoping this year, where we would add something that targets the epidermal growth factor receptor on the outside, cetuximab, a monoclonal antibody, to an EGFR inhibitor, for example, afatinib. And there was some very exciting data presented last year where about half of people had shrinkage of their cancer after it had grown on an EGFR inhibitor and after people had received chemotherapy. Also, a number of drugs where we're going to add something to an EGFR inhibitor. Probably the biggest ongoing trial right now is METMAB, which is very interesting. Some of these compounds have been less successful, such as the ARC-197 study, and there are also some compounds that target not only MET, but other things like AXL, ferretinib, and there's some studies ongoing with that as well. And finally, and I think that this is something that happens quite a lot out there in current practice, but it would be good to really design a study that helped us answer how helpful this is. People who've been on an EGFR inhibitor like Aresta or gefitinib or erlotinib or Tarceva, once the cancer starts to grow, should we just switch you to chemotherapy and give people a break off the EGFR inhibitor, or should we combine the two? And there's certainly been some evidence suggesting that this might be a very interesting approach. And this is a study that's ongoing in Europe and Asia, and we hope to hear more about it in the next 1 or 2 years.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.